Welcome to today's deep dive into the sources. I want to start you off with, well, a quick thought experiment.
Oh, I love a good thought experiment.
Right. All right, so imagine you wake up tomorrow morning, you don't have a fever, you don't have a cough, and you're not physically injured.
Sounds like a good morning.
Exactly. And by almost every standard metric we have, if you don't have an infection or a broken bone, you are considered physically healthy.
Yeah, the absence of sickness just equals health. We accept that without a second thought.
We really do. But I want you to think about your mind for a second. If you don't have a diagnosed psychiatric condition, so no anxiety disorder, no clinical depression, no schizophrenia, does that automatically mean you are mentally healthy?
That is honestly the perfect question to kick things off, because it immediately exposes this massive flaw in how we intuitively think about our minds compared to our bodies.
Yeah, it's like we treat them as two completely different systems.
We do. We are deeply conditioned by society to view health as this strict binary. Like you are either sick or you are well. There's no in between.
It's just an on-off switch.
Exactly. But the sources we are unpacking today make it incredibly clear that this on-off switch approach it doesn't work for the human mind.
No, it really doesn't. And let's really get into the weeds on this because our central mission for this deep dive is to figure out what the term mental health actually means.
Right.
And the most vital takeaway from all of this material, like the golden thread running through every source, is that mental health is far, far more than just the absence of illness.
It absolutely is. And to understand the mechanics of why that is, we really need to look at the World Health Organization.
Okay, the WHO.
Yeah. The most widely quoted definition of mental health actually comes directly from the WHO's founding constitution.
Which was written a long time ago, right?
Way back in 1946.
Okay.
Enforced in 1948, right in the aftermath of World War II.
Wow, okay.
And they boldly defined health as a state of complete physical, mental, and social well-being. And here's the kicker. Not merely the absence of disease or infirmity.
I love that specific phrasing, like not merely the absence of disease. It makes perfect logical sense when you apply it to other areas of life.
How so?
Well, think about it. If someone said to you, I have a perfectly healthy diet, and you asked them to elaborate on what they eat, and they just replied, well, I don't have scurvy.
You'd look at them like they were crazy.
Completely disconnected from reality. Defining mental health merely as not being mentally ill is exactly like defining a healthy diet as just not having scurvy. It's this incredibly low, almost meaningless bar.
That is a brilliant way to frame it. And that single revolutionary clause from 1946 is really the core of everything we're exploring today.
Right.
But if we establish that mental health has to be more than just not being sick, we immediately run into this complex new problem.
Which is, how do you actually find that more?
Exactly. What are the actual criteria for well-being?
If it's a moving target, we kind of need to know where the bullseye is.
The WHO certainly tried to paint that bullseye. Over the decades, they continually expanded on their definition to try and make it more concrete.
What did they come up with?
Well, they eventually described mental health as a state where an individual realizes their own potential, copes with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to their community.
Okay, now I have to pause and push back on that a little bit.
Go for it.
When I was reading through those specific criteria in the sources, my immediate reaction was, well, that sounds a lot like the definition of a good employee, not necessarily a well human being.
Oh, totally.
Like working productively and fruitfully, that feels a bit loaded.
You've hit on the exact criticism that sociologists and disability advocates leveled against that definition for years.
Wait, really?
Yeah. Critics correctly pointed out that defining human mental health around productivity and economic contribution actually smuggles in very specific modern capitalist values under the guise of medical science.
Wow. It's essentially measuring your internal peace by your external economic output.
Precisely. And more troublingly, think about what happens when you apply that definition rigidly.
You exclude a lot of people.
A massive portion of the population. If someone has a severe physical disability or a debilitating chronic illness, or they're just entirely outside the traditional workforce for whatever reason.
Right. Are we seriously saying they're incapable of being mentally healthy?
Exactly. By that strict achievement-oriented definition, they were excluded from the category of well.
That's awful. So I assume they changed it.
They did. Because of that intense pushback, the WHO eventually had to walk this definition back.
Which seems like the only logical move. So where did they land today?
In their more recent fact sheets, they've shifted to a much less prescriptive, more pluralistic model. They now explicitly describe mental health as existing on a complex continuum.
A continuum.
Yeah, it accounts for context, recognizing that people experience well-being very differently, with varying degrees of difficulty and distress. It's no longer this one-size-fits-all checklist of productivity.
So what does this evolution mean for you, the listener?
I think the big takeaway here is that there is actually no single, universally agreed upon operational definition of mental health today.
Not at all.
When you're chatting with a friend and they say, oh, scrolling social media is bad for your mental health, they're leaning on an intuitive cultural concept.
Right, it's just a vibe.
But underneath that casual phrase is a heavily layered term that professionals are still actively debating.
And because that definition has shifted from a rigid binary into this fluid continuum, we're forced to ask a new question.
How do you measure someone's place on a continuum?
Exactly. If we throw out the simple binary of sick or, well, what replaces it in the doctor's office?
Because public health systems still need a practical way to figure out who needs interventions. We can't just throw our hands up and say it's all subjective. Right, they need metrics. To solve that, experts use what's called a functional lens. Basically, starting from first principles, mental health is best understood and measured as a level of functioning, not simply as a feeling.
Let's underline that distinction because I think it's crucial. Functioning, not feeling.
It is the bedrock of modern diagnosis. We have to recognize that transient distress is a completely normal, unavoidable part of human life.
Like grief.
Exactly. Feeling profound grief after losing a loved one or having intense nerves before a major life event, that doesn't mean you have a psychiatric condition.
Right.
A clinical condition typically requires impairment that is persistent, entirely disproportionate to the actual context, and actively disrupts your daily functioning.
Like, can you get out of bed? Can you maintain relationships?
Can you feed yourself? Exactly.
Okay, so if we are looking at functioning, how do we map that out without just falling back into drawing a single line between healthy and sick?
We use this incredibly insightful framework called the two-continuum model.
To continue.
Yeah. Proposed in the early 2000s by a sociologist named Corey Keyes. He built this on a mountain of data from the positive psychology movement.
Okay, what's the core idea?
The core idea is paradigm shifting. Mental illness and mental health are not opposite ends of one single line. They are two entirely separate, though interacting, dimensions.
Wait, let me make sure I'm fully wrapping my head around the mechanics of this.
Sure.
Are you saying that someone with a diagnosed clinical illness like severe depression could technically be doing better mentally than someone with absolutely no diagnosis at all?
The data actually backs that up completely.
Wow.
Yeah, Keyes proved this using massive population surveys. Let's look at the two extremes his model highlights. First, you can have what he calls languishing.
Languishing, okay.
This is a state where a person has absolutely no diagnosable mental disorder. They don't meet the criteria for depression, anxiety, PTSD, nothing. But they report incredibly low emotional and social well-being.
They're just flat.
Empty. Disengaged from their community, no sense of purpose. They are just going through the motions of survival.
So they don't have an illness. A doctor would technically clear them, but they are absolutely not healthy or thriving.
Exactly the opposite of thriving. Now look at the flip side. You can have someone who absolutely meets the clinical criteria for an illness, say, chronic bipolar disorder.
Right.
But they are what Keyes calls flourishing. Through medication, intense therapy, a supportive social network, and meaningful work, they are coping with their symptoms beautifully.
That completely shatters the popular misconception that good mental health means just being happy and symptom-free all the time.
It's astonishing how deeply ingrained that myth of constant happiness is in our culture.
Right. People often think any negative emotion is a flaw or a symptom to be medicated away.
But experiencing deep sadness, profound fear, or righteous anger in proportion to real-world events is actually the hallmark of a functioning, healthy mind.
To use a blunt analogy, if your house burns down to the ground and you're standing on the sidewalk perfectly cheerful and unaffected.
That is not good mental health.
No, that is a dangerous disconnect from reality.
Proportionality and functioning are the keys to the kingdom here. And this two-continuum model is so vital because our global public health systems are currently built almost exclusively to catch diagnosable illnesses.
Oh, I see.
If we only ever scan the population for illness, we systematically ignore huge numbers of people who are languishing.
We miss the millions of people who are quietly struggling without ever triggering a diagnostic code.
Precisely.
It's fascinating that we now have these incredibly nuanced tools to measure exactly where someone sits on this spectrum. But that obsession with subtle measurement is actually a direct reaction against the way we used to handle mental health, isn't it?
Oh, absolutely. Almost a desperate reaction.
Mm.
Because for a very long time, the prevailing approach wasn't a continue and all. It was a brutal physical binary.
It was incredibly dark. To understand why modern medicine focuses so heavily on community well-being today, we have to look unflinchingly at the horrors this movement was reacting against. Let's travel back to 1908.
Set the scene for us.
Enter a Yale-educated man named Clifford Beers. He experienced severe manic depressive illness, and as was standard practice at the time, he ended up institutionalized in a series of mental asylums.
Right.
When he eventually got out, he didn't just quietly return to his life. He wrote a sensational, explosive memoir called A Mind That Found Itself.
And reading the background on this, he didn't just write a clinical diary. He wrote an expose.
A total expose. He documented systemic horrific abuse. He detailed casual beatings by attendants, the overuse of straitjackets for days on end, and just completely dehumanizing punitive conditions.
He radically reframed the concept of the asylum for the public. Like, it wasn't a hospital providing care. It was a penal facility that could actively destroy a person's mind.
Yeah. This is a detail that really jumped out at me from the sources. The organized public concern for mental well-being, this massive movement we have today, wasn't started by a brilliant doctor making a discovery under a microscope.
No, it wasn't.
It was started by a patient exposing systemic abuse from the inside.
That is a profound historical truth. The modern movement was born from patient advocacy. Beers used the massive public momentum from his book to found the National Committee for Mental Hygiene in 1909.
And he got some major backing for that, right?
He did. He got the famous philosopher William James and a highly prominent psychiatrist named Adolf Meyer.
And Meyer's the one who coined the term mental hygiene, which, feels like such a strange phrase to modern ears.
It does, but the use of the word hygiene was incredibly deliberate. Think about the sanitation reformers of the early 20th century.
Okay, like dealing with water and sewage?
Exactly. They were engineering sewage systems to prevent outbreaks of cholera and typhoid on a massive population-wide level. They weren't just treating sick individuals, they were treating the environment.
Oh, I see.
Meyer wanted to apply that exact same preventative logic to the human mind.
So instead of just waiting for someone to completely collapse and then warehousing them in an asylum for decades, you try to engineer a society that prevents the crisis in the first place. You treat the mind like the town water supply.
That is the perfect way to synthesize it. It was the birth of mental health as a proactive public health movement.
But pushing to reform these physical asylums revealed an even deeper, more uncomfortable philosophical problem, didn't it?
It did. Because as researchers started looking closer at these institutions, they realized that the act of institutionalizing someone entirely changes how we perceive their reality.
Which brings us to a terrifying question. How reliable were these psychiatric diagnoses in the first place? Were doctors seeing a disease, or were they just seeing a person locked in a cage?
Right. And that leads us to 1973 and what has to be one of the most famous and frankly wild studies in the history of psychology.
The Rosenhan study.
Yes. Stanford psychologist David Rosenhan published a landmark paper in Science called On Being Sane in Insane Places.
What did he do?
He and 7 other completely healthy volunteers essentially went undercover. They presented themselves at different psychiatric hospitals across the country and reported hearing a single, vague auditory hallucination. Just a voice saying the word thud.
Wait, not a voice telling them to do anything dangerous, just the word thud.
Just thud.
Mm-hmm.
And other than that initial lie, they acted completely normal.
So the moment they were admitted to the wards, they stopped claiming to hear the voice.
Exactly. They answered all other medical questions honestly. They behaved calmly. They were cooperative.
Yeah.
Yet all 8 were admitted, and most were formally diagnosed with schizophrenia.
That's terrifying. How long were they held?
They were locked in these wards for anywhere from a week to nearly 2 months.
Wow.
And here's where it gets chilling. While they were inside, the hospital staff interpreted their completely mundane, everyday behavior as symptomatic of their severe disease.
I need an example of that because it sounds almost like paranoia on the part of the doctors.
It practically was.
Yeah.
For instance, the volunteers were taking notes for the study, just writing in a notebook in the common area.
Okay, totally normal.
But the nurses observed this and literally recorded it in their medical charts as patient engages in writing behavior, framing it as a compulsive, obsessive psychiatric symptom.
You're kidding?
No. Pacing the halls out of sheer boredom was written up as nervous agitation.
The environment pathologized everything they did. But the twist in this story is what really gets me. It wasn't the highly trained psychiatrists who eventually realized these people were faking.
Not at all. It was the other patients on the ward.
Which is wild.
Yeah, a significant number of the actual diagnosed patients came up to the volunteers and said things like, "You're not crazy, you're a journalist checking up on the hospital."
The patients saw right through the ruse immediately.
While the medical staff were completely blinded by the context of the institution.
It makes me think of an analogy. Like, if you wear a tuxedo to the beach, people are going to stare at you and they think you're completely unhinged.
Right.
But if you wear that exact same tuxedo to a formal wedding, you blend right in. The clothes didn't change, the context did.
That's exactly it.
Once these volunteers were inside a building legally labeled insane, the context dictated how every single normal behavior was judged. The setting literally created the madness in the eyes of the doctors.
Context is everything. And this study became a massive, undeniable argument that psychiatric diagnosis at the time was dangerously context-dependent and subjective.
And this era of questioning psychiatric power in the 60s and 70s also brought about much more radical critiques of the whole system.
Which brings us to Thomas Szasz.
Yes, the psychiatrist Thomas Szasz. He published a hugely influential book called The Myth of Mental Illness in 1961.
And he argued a very controversial point that mental illness is literally just a metaphor.
Right. He pointed out that if you have a broken bone, an X-ray proves it. If you have a virus, a blood test proves it. But most psychiatric diagnoses at the time were defined entirely by a checklist of socially unacceptable behaviors.
There was no discoverable physical lesion in the brain they could point to.
Now, it's important to clarify from the sources that this remains a minority position among clinical psychiatrists today, especially with advances in neuroscience. But we can't ignore Szasz, because his argument permanently shaped the legal and ethical debates around involuntary commitment. If it's just behavior, do we have the right to lock people up for it?
And that debate wasn't just happening in academic journals. It was happening alongside massive, highly publicized, real-world tragedies that ultimately forced the government's hand.
Like the Kennedy family tragedy.
Yes. One of the most famous tragic failures of the purely biological surgical approach involved Rosemary Kennedy, the sister of President John F. Kennedy.
What happened to her?
In 1941, when she was just 23 years old, she underwent a prefrontal lobotomy. The medical intention was to treat her mood instability by physically severing connections in her brain.
And it went terribly wrong.
It was a catastrophic failure. It left her permanently, severely mentally, and physically disabled for the rest of her life.
Which is an absolute tragedy, but it had a massive ripple effect on policy, didn't it?
A profound effect. That deep personal family tragedy is widely cited by historians as a major influence on JFK's political priorities. When he became president, he pushed aggressively for the Community Mental Health Act of 1963.
Which funded local community mental health centers and helped accelerate a massive shift called deinstitutionalization.
Yes. The goal was moving care out of these giant, remote, prison-like state asylums and putting people back into their local communities.
That was the dream. But deinstitutionalization is heavily debated today.
Very much so.
On one hand, it succeeded in finally ending the worst of the institutional abuses that Clifford Beers fought against. But critics vehemently argue that in the U.S., we closed the asylums, discharged the patients, and then completely failed to build enough community infrastructure.
We didn't build the housing and outpatient clinics to replace them.
We closed the bad system without actually funding the good system, which leads to millions of people falling through the cracks into homelessness or the criminal justice system.
Enormous gaps in care that define the crisis we still see today.
So this leaves us with a massive practical question. If locking people away in remote asylums was damaging, but just shutting the doors of those asylums left huge gaps in care, what does successful holistic care actually look like in the real world?
Well, if we look for historical solutions, we actually have an incredible real-world proof of concept for effective community care. And surprisingly, it dates all the way back to the 13th century.
I found this part of our research absolutely fascinating. The town of Geel.
Yes, Geel, a city in Belgium. Its history is tied to the legend of Saint Dymphna, the patron saint of the mentally ill.
And what do they do differently?
For literally centuries, local, everyday families in this town have taken in people with severe mental illness as boarders. They literally bring strangers with psychiatric conditions into their own private homes to live with it.
And to be clear, they don't lock them in a basement ward. The mechanics of this are about total integration. Bakers, farmers, everyday townspeople are taking them in.
The integration is the therapy. They eat meals together at the family table. The boarders work alongside the townspeople in the shops and farms. They are included in community events.
So they aren't treated as medical patients to be cured.
No, they are treated as neighbors with unique quirks. It is an accidental, centuries-old model of adult foster care. And modern historians and clinicians point to Giel as undeniable proof that social inclusion and just the ordinary, predictable structure of daily life can be highly therapeutic.
In many cases, far more therapeutic than clinical confinement.
Exactly.
It's a beautiful concept. It proves that humans are fundamentally social creatures, and you simply cannot heal a social creature in total clinical isolation.
Which perfectly sets up the modern scientific framework we use today. For a long time in the 20th century, psychiatry was heavily dominated by the strict biomedical model.
That's the idea that mental illness is purely and entirely a biological brain disease.
Right? Like a tumor, to be treated solely with physical or chemical interventions. But in 1977, a physician named George Engel published a paper in Science arguing for a paradigm shift.
This is the biopsychosocial model.
Precisely. Engel argued that if we want to actually heal people, we need to treat biology, psychology, and the social and environmental context as jointly causal. You can't just look at a brain scan.
You have to look at all three pillars interacting together. Can you give me a concrete, real-world example of how those three pillars actually interact? Because I think this hits on a massive cultural misconception. We constantly hear the phrase chemical imbalance in pop culture. Like, oh, depression is just a chemical imbalance in the brain, take this pill and it's fixed.
That chemical imbalance narrative is a massive oversimplification of decades of complex research.
So how does Engel's model actually work?
Say a person develops severe depression. The biological pillar might be a genetic predisposition to low serotonin they inherited. The psychological pillar might be a tendency to internalize failure and suffer from low self-esteem.
Right.
And the social pillar might be that they just lost their job, they are facing eviction, and they have no friends nearby.
Wow. So if you only give them a medication to address the biology,
You haven't fixed the fact that they are isolated and facing eviction.
a medication might give them the energy to get out of bed, but it doesn't pay their rent or give them a support system.
Exactly. Medication can be a vital, life-saving tool for that biological pillar, but it cannot fix a toxic environment or deep psychological trauma or extreme poverty.
The biopsychosocial model tells us that effective, lasting treatment usually has to combine medical care with psychological therapy and actual, tangible social or lifestyle changes.
There is no single magic bullet for the human mind.
So, zooming out and bringing all of this historical and scientific context together, why does grasping this nuance matter so much for the person listening right now?
Because the global stakes are incredibly high. According to the WHO's latest assessments, mental health conditions are consistently among the leading causes of disability worldwide.
It's massive.
They don't just cause invisible internal suffering, they measurably limit how much of life people can actually participate in. It shapes how you are able to work, how you parent your children, how you study, and how you relate to the people you love most.
It touches absolutely everything.
It is the foundation of a lived life. And when we finally understand mental health as a two-continuous spectrum, rather than a simplistic binary of sick or well, it completely changes what help looks like on a societal level.
Meaning we can't just invest all our resources in emergency crisis centers for people who have already broken down.
Exactly. We have to invest heavily in the everyday baseline conditions that dictate where people sit on that continuum in the first place.
We're talking about the infrastructure of a good life. Things like guaranteed safe housing, access to nature, social connection, having meaningful, fairly compensated work.
Yes, those aren't just luxuries. They are public health necessities. And perhaps most importantly, viewing mental well-being as a spectrum finally collapses the societal stigma.
It destroys the arrogant idea that there is an us, the healthy, normal people, and a them, the mentally ill.
It collapses that false binary into a single shared human axis that every single one of us moves back and forth along throughout our entire lives.
Which is exactly the humane, empathetic reframing that Clifford Beers was fighting for when he was suffering inside that asylum back in 1908. We are all on the continuum.
We all are. There's no escaping it.
I want to leave you with a final thought to mull over as we wrap up this deep dive. We started today by talking about physical health, how we treat our minds differently than our bodies, and how pioneers like Adolf Meyer realized we needed to treat our mental hygiene the exact same way we treat our city's water supply to prevent widespread illness.
Right.
Well, if George Engel's biopsychosocial model is right, and our social and economic environments are just as vital to our mental health as our genetic biology, could we eventually reach a point in society where we view a highly toxic, abusive workplace or an entirely unaffordable housing market as a literal public health violation?
That is a phenomenal question.
Could we one day see those things as just as dangerous and just as unacceptable as a contaminated town water supply? It's a heavy question, but it's something to think about the next time someone tells you they're just trying to stay healthy. Thanks for joining us for this deep dive. See you next time.